pleasure for me. Thanks for the invitation. So I'm going to share with you some of the results we have on this quite large database we've managed to assemble to the contributions of all these researchers from a group called Foro LATAM, Foro Latin American Forum in MS NMO research. And we've assembled for the first part of our work 208 cases of NMOSD, almost half of them from my center, another center in Guadalajara, in the west of Mexico, Ecuador, Panama, Chile, Argentina, Brazil, and Colombia. And as you all know, most of our cases are women with a quite wide range of ages, from 19 to 93 years old, mean age 45 years, and mean years of education 12 years. We were very interested to understand or analyze if there was application of education, social variables, economical variables in prognosis, as Ethel told you, and only one case with family history of NMOSD. So we have quite a bias because most of our centers are reference centers and academical centers, university-based. So most of our healthcare or patients come from this public health services in different countries and in cities, obviously. But we have assembled almost 6% of patients who are actually living in a rural setting, and a third of them with a low socioeconomical level. It was quite difficult to assemble like a uniform variable to determine a low socioeconomic level in so many countries, but we used these variables. So variables related to a poor housing, facilities, resources, or if there was a formal socioeconomic evaluation telling us that these patients had a low socioeconomic level. Patients had comorbidities, mainly autoimmune comorbidities, as has very well been documented in NMOSD, mainly rheumatological disorders like lupus, and other non-autoimmune comorbidities, which are also frequent, as you have seen with such a wide age range and many patients over 50 years old. And so the NMOSD syndromes, the most common presentation at the beginning of the disease was optic neuritis, followed by myelitis. And at the end of presentation, last clinical record, most of our patients had recurrent events with a combination of optic neuritis and myelitis, as has very well been documented in NMOSD. And it's quite interesting that or the majority of patients then have been recurring despite diagnosis of NMOSD, and like 70% of patients have persisted with relapses. Areopostrema syndrome, brainstem syndrome, encephalitic syndrome were quite infrequent in this registry. And as you can see in this slide, there was there were quite interesting results regarding the errors in diagnosis of NMOSD. 16% of them were initial diagnosis MS, and they remained in this wrong diagnosis for quite some time, with a mean of 48 months. One patient spent with a wrong diagnosis almost 20 years, and 21% of patients had no diagnosis related to MS or NMOSD. For example, we had patients diagnosed as myasthenia gravis, neuropathy, psychiatric syndromes, just optic neuritis with anything else, etc. So in almost 40% of patients, the initial diagnosis was not NMOSD, and this is quite striking for us. The clinical phenotypes, as I told you, is not very different than other registries. So the optic neuritis patients were very frequent. Almost 70% of patients had, at some time during their presentation, had optic neuritis. And we had quite a few cases of severe optic neuritis characterized by the need of plasmapheresis or IGIV, severe visual loss, blindness, bilateral events, or quite a disability in the clinical functional scores. And with the changes in their MRIs in some of the cases, not every case was registered as an MRI specific to the optic nerve. The myelitis cases were also severe, and 75% of patients had events of myelitis. And as you can see, for example, severe myelitis characterized as an EDSS of 4 or worse, or the need for a walking aid was quite frequent, as well as the need for plasmapheresis, IgIV, urinary catheters, or longitudinal findings on MRI. For example, hyperintense bright spot lesions were registered in 87% of patients who had a spinal MRI. And regarding the access to tests and the results, anti-aquaporin 4 antibodies were available only in 61% of patients. This is quite striking. And most of the results were processed in the serum, and the positivity rate was only 71%, which is not very different from other results we've had in Latin America in general. Anti-MOG antibodies were only available in 4 cases, 11.5%, but once were ordered, the positivity rate was quite high, 35%, but this is something else. Lumbar puncture was done in 58% of patients. This is not different than in other findings in NMOSD. And quite striking is that we only had the brain MRI in 56% of patients. Regarding treatments, you can see that the most common initial treatment was azathioprine, but at the end of the registry, many patients had switched to rituximab. Many patients at the beginning had obviously treatment with steroids, but that was lower in follow-up. And also the use of other immunosuppressants, for example, mitoxantrone, methotrexate was not as frequent as in other registries. And we still had cases who had MS-related treatments like beta interferon, and I have one patient treated with ocrelizumab because of an initial MS diagnosis, but we know that it may work in NMOSD as well. Regarding relapses, so before diagnosis, there was a mean of 2 relapses, and this was lowered with a first treatment and lower at the end of the registry. So it seems that our patients on follow-up tend to be or have a better disease control, but we have some patients are quite active. And regarding outcomes and disability, 38% of patients needed a walking aid at the end. Blindness in 50%, that's 25% of our sample, with a mean EDSS of 3.8, and we have 7 deaths at the moment. All of the patients who have died had history of severe myelitis, urinary catheters, and the need of a walking aid as an EDS worse than 6. Regarding safety, complications related to DMTs were reported in 7% of patients, and this was the reason for the need of change of treatment in 73% of the patients who switched. And these are some of the adverse events that were registered. Nothing is striking or different that has been known. We had patients with complications related to steroids, for example. And the most frequent infections were urinary tract infections, sacral ulcers, pneumonia, herpes. 3 patients developed cancer after the diagnosis of NMOSD. All were treated with immunosuppressant drugs. And causes of death, mostly infections. I had one patient who died due to a complication, regarding the insertion of a catheter in the aorta. And one patient was only registered as cardiac arrest. Only 6 pregnancies registered is quite low, the percentage of women who have had pregnancies after NMOSD. And we had 2 abortions, 1 ectopic pregnancy. And regarding the variables that may be associated with this disability and death factors, we found that there was a very small impact of age. This is very heterogeneous because of the sample, but was an impact on the need of walking aid, of course, in the EDS3, worse than 3 because it's redundant because of the EDSS, of course. But there was an impact on the history of severe optic neuritis and aquaporin 4 antibodies, and I forgot to write this, but also a history of infections. And for the EDSS equal or greater than 6, we also find that a history of severe myelitis patients who were initially treated with rituximab or had to change treatment because of lack of efficacy, a higher risk to have an EDSS worse than 6. And patients who had to switch treatment, the main reason for treatment change was the persistence of relapses. So patients with who initially were treated with rituximab had a lower risk to need to change treatments. And of course, patients who persisted with relapses had a higher risk to need to change treatment, or eventually were changed. And the higher risk factor for death was the history of infections. As you saw, it was the cause of death in 5 of our 7 patients who died. So this registry has shown us that there are some factors that could be related to disability. We found a small impact of age, higher impact of myelitis and the disability related to the history of myelitis and functional scores, an impact of the positivity of anti-aquaporin 4 antibodies. Maybe the initial use of rituximab, this could be biased because we usually treat with rituximab the more severe cases, and of course infections. We saw we could have a lower risk of DMT failure if we initially treat these patients with rituximab. Of course, patients who develop infections are in a higher risk of death. And I've told you the phenotype of the patients who died. And it's quite striking that only 61% of patients, as I told you, all of these patients had a confirmed diagnosis of NMOSD, but only 61% of the patients or the centers had this test available. So there was an impact, of course, in the change of the diagnostic criteria in 2015 that allowed us to diagnose patients despite not having this test available. And I think that's a very important issue in Latin America in general. There was a large delay in diagnosis, lots of wrong initial diagnosis. So we, of course, have identified a need for education activities related to the diagnosis of NMOSD and its distinction from MS and, of course, any other neurological disorders. So at the moment we are preparing 2 manuscripts, one related to a more descriptive kind of work related to clinical factors, diagnosis in general, and the second work is more focused on the potential risk factors for disability and death in this registry. So I want to thank you all for your interest and the opportunity to share our results with you. Thank you.
Thank you, Irene. I don't know if some of our of the public want to ask some questions. Emmanuel, please.
Yeah, so thank you. It's a very nice word because it's so hard to do something international. That I commend you for gathering all this information from across, very different countries. And I'm sure, so I have 2 questions. One is about the patient who had a family history of NMO. So was that patient actually a patient who was confirmed with AQP4 antibodies and the other member of the family as well? And what was the relationship? Were they first-degree relatives or second-degree relatives? And the other question is about, are the medications such as azathioprine and mycophenolate mofetil and rituximab available in all the countries that have contributed to the cohort?
Thank you. So I understand the family case of NMOSD are brothers. One is positive and the other one is negative. The positive case has optic neuritis and a history of optic neuritis and myelitis. We don't have that patient in our registry. We have the other patient who is negative and has only had recurrent events, but no antibodies positive at the moment. And yes, so all of the centers are specialized centers with reference centers for NMOSD and in general neurological autoimmune disorders. So all of the centers have these DMTs generally available. no centers at the moment as far as I know, and at the moment of the database had satralizumab or any of the newer drugs available.
And any, so the drugs are available, are they broadly available in general because health insurance would cover it? Or do you think that there's a lot of differences across the different countries about access just because of coverage of the expense?
Oh yes, there are huge differences, mainly regarding the coverage of public health services. For example, in Mexico, it's a disaster. In other countries like for example, Argentina, it's more homogeneous, or Panama, but many other countries, Ethel is here, for example, Chile is also quite heterogeneous. You have public patients and private patients. So yeah, it's very, very difficult, very, very difficult to homogenize those variables. Yeah. We don't have any patients from, we don't have many patients from Central America precisely because of that. There are countries where there are no registries, Honduras, Nicaragua, countries like that. So we don't have lots of data over there. Thank you.
I can add that in Argentina, you have both systems, private and public, but you have access to the 3 drugs, even in public or even in private. It's more easy to get rituximab if you are in private, of course, but you can get both. Yeah.
Thank you.
Great, thank you so much. That was a really, really interesting presentation. So we will go on with our second presentation for today. So Dr. Sonam Dilwali is currently a 4th-year resident at UCSF in the neurology residency program, and is planning to pursue a clinical fellowship in neuroimmunology at UCSF as well. She's currently conducting clinical research under the guidance of Dr. Narayan at UCSF, understanding the role of micro and macronutrients in modulating risk for relapses in pediatric MS, which I believe we're going to hear about today. So without further ado, I will pass it off to Dr. Dilwali.
Thank you so much. I really appreciate this kind of opportunity to present. I wanted to talk a little bit about the research I'm doing under the guidance of Dr. Wabant, which is trying to understand the association of dietary intake and pediatric multiple sclerosis disease activity. And this is really work that is in collaboration with the US network of pediatric multiple sclerosis centers, so all over the country. You guys can hear me okay? Great. Yep. All right. So I thought I'd kind of take a global view on asking even why should we even study diet? Of course, there's a need to study diet because it could be a modulating factor in controlling diseases like, especially with pediatric MS, where we worry about long-term toxicity of some of the medications that can be used for multiple sclerosis. And specifically also, we know that there are in fact lifestyle factors such as smoking, diet, and exercise that can impact the risk of development and progression of MS. And independent of that, we do know that dietary metabolites, vitamins, fats have direct effects on the immune system and the brain. And taking that one step further, we're starting to really uncover the kind of the influence the gut microbiome may have in modulating diseases like multiple sclerosis and other CNS processes. So I wanted to first take a step back and highlight the current understanding in the field around diet and multiple sclerosis. My work is that I'm presenting today, it's really a kind of a larger work with the established database that has had a publication previously. So we found back in 2018 under Dr. Wabant and others that in pediatric onset MS, high energy intake from fat, especially saturated fat, may in fact increase the risk of relapse, while vegetable intake can be independently productive. And here's a graph kind of really outline that, where you see years from study enrollment on the x-axis, event-free survival on the y-axis, and you see with vegetable intake, if you divide it up into different tertiles, you see that the upper tertile can actually seem to have a higher event-free survival in this population of pediatric MS. We also, interestingly, I went back and tried to find if, there are specific nutrients that might be related to prevalence of MS. And there are many studies hinting at this. One I wanted to highlight was that prevalence of MS has shown to correlate positively with intake of calories from animal origin and with dairy intake previously. So this study was published in 1992, but all they did is really look at the milk consumption in 27 different countries here on the x-axis and MS prevalence in those countries. And you can see there's a relative correlation there between the amount of milk consumed and MS prevalence. And we recently have some literature that's quite exciting to support the idea of trying to understand diet's roles, such as the study published by Kat Sands et al. In 2021, where certain dietary lifestyles, such as the Mediterranean DASH diet that we often use for understanding the impact of diet on cardiovascular health, is in fact found to have a correlate with decreased radiographic markers in MS. Something like lesion volume can actually be decreased in some patients who intake a lot of dairy, or in certain types of fat, like omega-3 fatty acids, can also impact lesion volume in a positive way. And lastly, kind of hot off the press, very recently in December 2021, Mirza et al. Under the guidance of Dr. Wabant and Dr. Tremlett had published this idea of trying to parse out the gut microbiome between pediatric onset MS cases versus controls, and found that, in fact, there is a difference in the functional potential and taxonomy between individuals in the gut microbiome for these populations. So the literature is surely building up, and I think it's an exciting time for understanding the role of diet. So I'm working with the group to understand the association between the macro and micronutrients and subsequent risk of disease progression in children with MS. So I just wanted to give an overarching view of our study, which is where we studied macronutrients like carbohydrates, proteins, and fats, and micronutrients like vitamins and minerals. And we collected this data from patients with pediatric onset MS and their caregivers across 21 different US sites. So I've highlighted some of these sites here in this map of the network of pediatric multiple sclerosis centers. And we really use the data saying, well, depending on what you eat, how do we see your longitudinal progression in terms of your disease clinically as well as radiographically? So diving into a little bit more details of study design. This is a prospective observational multi-center study. It does expand on the prior work that I highlighted by Azari et al. Back in 2018. And the reason we wanted to relook at everything is because now we can have a larger cohort. So we have about 374 children instead of the 200 in the Azari et al. Paper. And we also can do this over a longer duration. And we're specifically also interested in neuroimaging outcome metrics, as well as clinical metrics, which have not been described before. And we also try to expand on trying to use some more nutritional predictors as a more kind of generalized approach to diet rather than focusing on certain nutrients. And I'll talk about the nutritional predictors as I share my data. So we enrolled across the 21 sites. We had the caregivers all do a food frequency questionnaire at the time of enrollment. We followed these kids for on average 2 years, plus or minus 5. The maximum was around 3 to 3.5 years. And we then looked at their clinic MS burden, which was measured with a clinical relapse rate, as well as we also looked at EDSS progression when possible. And we also looked at radiographic MS burden by looking at T2 progression on serial MRIs. As I mentioned, our population was about, at the end, 374 children. We had, the ages were about at 15 years old, plus or minus 3 years. And their usual time for MS at the time of enrollment is about one year. You can see we did recruit somewhat of a diverse population, 64% female, 63% white, and 36% Hispanic. And most of these children over time did get onto DMTs. So about 90% were on DMTs for for most of the study. So here's the results, and I'm showing you the raw data first, and I'll kind of summarize after. So for clinical relapse, we found that each cup of fruit intake decreased the hazard risk by 18%. And there was also this trend that we had seen in the Azari paper, follow up here, with vegetables being protective. So here I'm showing you the hazard ratios and the p-values and then the different nutrients that we studied. Most of these did not turn out to be a significant correlation, but here you can see the fruit, every cup equivalent of fruit did have an impact of decreasing hazard of relapse in the clinical relapse group. And then for the clinical relapse on the rest of the data, we did find, interestingly, that if you have extra dairy, then you also increase your hazard of relapse. So each excess of dairy by 50% of recommended intake increased the hazard by 52%. So that was quite significant if kids were taking excess of dairy based on the survey. And this not only came out to be true by just the recommended dairy intake guidelines by the USDA, but it was also true if we just look at the raw data for dairy. In fact, every cup equivalent of dairy extra caused increased the hazard of relapse by 37%. Significant. And the last thing I'll highlight is going back to the expansive nutritional predictors. One of the nutritional predictors, what we tried to use was the healthy eating index, which I'll go into in a bit, but it basically takes many different nutrients into account. And the kids that were following, having a higher healthy eating index and following a diet more consistent with a balanced diet, they actually had a decreased risk of relapse by about 17%. So in summary, for the clinical relapse group, we find that this is the forest plot, and I'm showing you all the data together, that there are a few variables that increase and decrease clinical relapse. So hazard of clinical relapse, here is showing you the hazard ratios on the y-axis, on the x-axis, and on the y-axis I'm showing you the dietary variables. And the ones that I'm highlighting that I think are significant are the dairy, cups of dairy. You can see that they're falling here. And then the healthy eating index and the fruit intake, which is showing up here as significant in terms of reducing relapse risk. And I did want to go back and highlight the healthy eating index itself. It involves many different nutrients. The ones in orange are the nutrients that it considers negative, as a negative addition to the healthy eating index. And the ones that are considered, that are shown in green, are positive, for as in a good food group to eat to increase your score of the healthy eating index. So looking at this as a cumulative score, we again found that kids who were having diets that fell on a higher scale for the healthy eating index were had a correlative decrease in clinical relapse. Okay. So then we looked at the MRI studies to see if there's anything that pops up there. And the only really major correlation, again highlighted, was dairy. So kids that were having extra dairy, so every cup of extra dairy, led to an increased hazard ratio, hazard of relapse by 28%. And that was the major significant finding here. So dairy seems to be present in both the clinical and the radiographic progression as a possible nutrient that will cause increased risk of disease progression. So this is just the rest of the data for your T2 progression, and there were no changes here for other nutrients. Again, just a summary here, cups of dairy was the only major one. You can see that the recommended dairy intake, again, was kind of tending towards also being significant, but was not significant. And generally the fruit and the vegetables are also kind of tending in some certain directions, but really not significant in the T2 progression. So the data was quite different than the clinical in the other nutrients. Okay, so then we go back and ask, well, what's dairy got to do with it? And I wanted to highlight kind of a potential mechanism. I think this is very hypothetical. We but I wonder if something there is a way to tie it all together. So this paper, as I was mentioning earlier, was published very recently in December 2021, and they highlighted that there were certain archaea that were more prevalent in kids with multiple sclerosis versus controls. And methanobrevibacter was one of them. And generally the pathways that were associated with this archaea were highlighted as higher in children with MS in their gut microbiome. And well, this was an interesting finding. I also tried to see maybe dairy has something to do with this type of archaea being present more so in the gut. And in fact, there is a study that's published back in 2017 where methanobrevibacter seems to be present in milk products, according to the study, and it might actually determine this methanobrevibacter gut colonization in children for kids who are drinking milk on a regular basis. So regular intake of organic milk had an increased odds ratio of having this presence, as well as yogurt. So I thought this was really interesting because I wonder if the kids that are having more milk are actually influencing their gut microbiome, and that it could be possibly why they have more active disease. Of course, this is just a potential mechanism to try to tie it all together, but it is definitely was intriguing for me to think about. Of course, I also think there are limitations in the type of study that we're doing. I want to highlight, it is an observational study. We only use a one-time dietary screener, and we're also evaluating for general nutrients such as dairy or fruits, but not really honing into specifics there. So that could be also more insightful in the future to really, if we have enough power, enough of a large group, to really pinpoint, maybe there are certain fruits or maybe there's certain types of dairy that's more harmful or more protective. Well, I just want to end by saying we have yet another reason in our books of reasons to eat a healthy, balanced diet. We are seeing that, we're finding more and more connections between the brain and the gut. And our study really, in this specific cohort, highlights that maybe fruits are better for you and dairy in lesser quantities might be better, especially for thinking about MS disease activity. Thank you.
Great, thank you so much, Sonam. That was really interesting. We'll open up for questions from the audience. Please just go ahead, or you can raise your hand and I can call on you, whatever you prefer.
I was just going to do a quick comment. I thought that was so cool. Sorry, Manuel. Thank you for highlighting Ali's work. I know he's actually away this week, and I know this gets recorded, so I'll send it to him because he'll be thrilled to know you're looking at this. And I might follow up with you guys to see if there's any way, we can collaborate and maybe validate some of your findings in Canada. But we have some issues. We have the Block Kids screener, but we have some issues with we have the MRI data as well. We just have some issues in terms of not so many of our kids have relapses, so it's challenging to look at that as an outcome. But anyway, I'm distracting. Emmanuel, you had a question.
I didn't have a question. I just wanted to ask Sonam if she wanted to say something about the inflammatory, I don't remember, the inflammatory index, right? Because that's, when we were starting to look at the different indices that have been kind of published for different disorders or health, it was actually challenging to pick one that would be relevant and also that could be quantifiable. So it's pretty challenging that, the status of the literature is pretty kind of heterogeneous and challenging.
Yeah, the indices that we finally settled on, and the one I've highlighted is the healthy eating index because there was a positive finding, was that one. And then we did the dietary inflammatory index, which I would say is still in the works because like Emmanuel's saying, there's just so many permutations of a dietary inflammatory index. So we didn't find anything overtly positive, but I wonder, you know, in the future, if we hone into the right variables, we could. And then and then the Mediterranean DASH diet, which was studied in adults, as I mentioned in that radiographic paper, looking at lesion volume and the Mediterranean DASH diet, you know, kids are harder to study with the DASH diet. They just usually aren't eating Mediterranean diets as much. So that was one reason we did not use that one, but we definitely considered it as well. So it is definitely will be interesting to see if we can give parents or caregivers like better guidance on generally the principles to follow in a diet.
Great, thank you so much. We can actually we have time actually for a few more questions. We're just waiting for our last speaker to join. He's just having a few technical difficulties joining. So feel free if you have any other questions, or if not, we can pause for just a minute or two and we'll get Ram on the call.
I guess I would just ask, where are you going to go next with this analysis? Meaning that, are you going to done and get this published, or you have additional questions you're going to ask? Because there are so many different ways you can look at diet. I mean, I think you've done a really great job, and I think it's so interesting, but I'm just curious.
Yeah, I think we definitely have something exciting that we want to share. So we'll try to go through the publication for this, but I know Emmanuel and we're still working on collecting kind of serum samples and stool samples to see if we can find any ways to correlate some of these things as the next step, to match some of the screeners and some of the progression that we're seeing with actual objective numbers in serum and stool.
And forgive me if you said, I was trying to, I don't think you did. Did you adjust for any sort of potential confounding factors in your analysis, or is that another step? Forgive me if you said I missed it. Oh,
yeah, we were, we adjusted, for example, for the vitamin D index, we adjusted for socioeconomic status. There were a few things that we adjusted for BMI. So there's a list, and then we actually also kind of made them all covariates. So then we kind of tried to basically adjust for every other variable while trying to isolate one of them. And Emmanuel can expand further on that.
Yeah, no, I wanted to expand on one thing we were hoping to be able to do, but I'm not sure at the end we'll be able to have enough data points, is we wanted to also look at progression of disability on EDSS or SDMT, because these are data that are collected maybe not as extensively as the relapse and the number of new lesions on recurring MRIs. But I think that at this point, it's really challenging actually to have enough EDSS data points, right, Sonam?
Yeah, the EDSS progression, we did try to do it, but there's nothing that's panning out positive and a lot of dropout.
And so with pediatric MS, one of the challenges that the EDSS is not progressing as much as in adults, especially because, luckily more and more now patients are treated appropriately, but children tend to recover better from their relapses in adults. So the EDSS traditionally is not something as sensitive to disease progression. And we were hoping that SDMD may be another way to look at the data, but again, we may not have enough data point to look at that. And we're trying to follow up also with an ongoing study that has a more in detail dietary questionnaire as a follow-up to this, and looking also at lipidomics and metabolites of lipids in the serum, the plasma of these patients.
Here's the specific things we adjusted for. So we have a list here.
Oh, I see. Thank you. Yeah, it was under the figure. Thank you.
Hi, so our last speaker is having some trouble with his presentation, so he's going to send his slides to Karina. I will present him just in 1 minute. He will be speaking about telemedicine in the practice of multiple sclerosis. And I will introduce him.
He's going to be on just right away. He's just joining now. I've got his slides, so sorry, everybody.
Perfect.
We're just going through some difficulties here, but he should be here just right away. I'm just bringing up his slides. Okay, you guys let me know if you can see the slides.
Yes.
Yeah,
Yes,
great.
perfect.
Thanks. Okay, so we'll just wait for him to join here. Hopefully he can. If not, maybe I will be giving the presentation. Sorry, everybody. He's just putting in his code right now. I'm just getting the play-by-play. Sorry, he's coming. Here we go. He's just joining now. Hi, Ram, are you there?
Yes, I am.
Hi, how are you?
Good. Can you hear me?
Yes.
Yes, perfect.
I've got your slides loaded up here. So if you want, you can just let me know when to advance the slides.
Well, I'm ready.
Sure. Ethel, did you want to just give him a quick intro?
Yes, Dr. Narayan is a neurologist in the multiple sclerosis program and assistant professor of neurology in the Department of Neurology at Barrow Neurology Institute. And he is a board certified neurology at the American Board of Psychiatry and Neurology. Dr. Narayan's expertise includes the diagnosis and treatment of MS, NMOSD, neurosarcoidosis, transverse myelitis, autoimmune encephalitis, and other immune-mediated and infectious disorders. And he will be presenting the utility of telemedicine in the practice of multiple sclerosis. Thank you.
Thanks a lot for that kind intro. It's my privilege to present at this conference. I'm sorry I'm a few minutes late. I had some technical difficulties logging into Zoom. Well, let me get started off right away. So this study is a questionnaire-based satisfaction survey for telemedicine-based care in multiple sclerosis and related neuroimmunological disorders. My name is Ram Narayan. I'm a staff neurologist at the Barrow Neurological Institute. So as a background, next slide, please. Can you guys hear me well?
Yep, we can hear you.
Okay. So telemedicine has had a significant impact on patient care since the emergence of the pandemic. And telemedicine-based care has already been studied in patients with multiple sclerosis, but really has not gained momentum until the current pandemic situation, at least in the United States. Virtual patient encounters could reduce the risk of transmission of infection to both the patients and the providers. Next slide, please. Next slide. Oh, okay. Oh, okay. So, so the aims and objectives of the study are assess the effectiveness and level of satisfaction amongst patients in providing telemedicine-based care in the practice of MS, and assess interest in continuing telemedicine-based care in the future beyond the pandemic. Next slide, please. So what we did was the patients for this study were ambulatory patients, were outpatients completing a telemedicine encounter, and they were consecutively chosen. They were sampled consecutively to minimize bias. And that a text message was sent to assess interest in the survey. And those responders that said yes were offered a survey questionnaire with related metrics via their email. And they were notified about the email, and a consent was obtained as part of the survey. So patients were contacted until the desired number of responses were obtained. And the period of encounters was from March 2020 to March 2021. And the patients were contacted between November 2020 and March 2021. So there could be a possibility of some recall bias in the survey in the study. Next slide, please. So these were the survey metrics that we looked at. So we looked at 3 different metrics. One is visit and connection related metrics, satisfaction metrics, and we also asked open-ended questions. So some of the visit related metrics included, was this a new patient or a established patient visit? Was this their first visit with a neurologist? Were they familiar with the audio-visual platform that was used? What was the device that was used? Did they need any language interpretation? And then satisfaction metrics were things like their overall level of satisfaction after the visit, pre and post check-in, pre and post visit procedures, clinical history, and physical examination based metrics. Questions like, was the provider responding to emotions? Was there adequate face-to-face time? And what was a future preference with respect to encounters? Is it telemedicine or in-person visit? And then open-ended questions were questions like, what were some favorable aspects of telemedicine? What were some unfavorable aspects? Did you save any time in doing this telemedicine visit? Because we know a lot of our patients come from 8 hours and 6 hours of drive, and they pretty much take a whole day off to come to our clinic. So we thought that was a significant area to question. And also, expenses for, gas and travel. And sometimes they come and take they stay in a hotel here before, when they're trying to see us. So this is, it's quite an ordeal for patients to do an in-person visit, particularly if it's a regular follow-up visit. And then what were some areas of improvement? So we asked them that as well. Next question. Next slide. So we sent our survey to about 210 patients. We had about, so about 210 patients consented to the study, out of which 109 patients attempted and 105 completed the survey. So only half of the patients that responded with a yes to our text message completed the survey. 82% of them were seen as follow-up visits. So the majority were follow-ups, and the majority, about 80%, were patients with multiple sclerosis. It's very important to note that 70% of our patients, so 2/3 of them, were satisfied, very satisfied with their visit. Next slide, please. With regards to connection metrics, 94% had high-speed internet connection, and 63% used audiovisual platforms on a regular basis, so other than doctor visits. And the majority used their laptops, and some, just like myself now for this conference, also used their cell phones for the visit. Now, with regards to satisfaction metrics, so for the question as to what was their overall level of satisfaction, we see that out of the 105 responders, close to 40 of them were very satisfied, and about, so 40% were very satisfied, roughly, and about 35% were satisfied. So, so about 70% of them reported very good satisfaction levels. And when we asked them how satisfied they were specifically with provider interaction, again, we get close to 70% for that as well. And then with regards to the clinical history, whether they were able to convey all their points in their history, again, the satisfaction levels were close to 80%. 80 was above 80%, I would say, out of the 105 patients. Now, with regards to clinical examination, the satisfaction scores were not as robust as with the other questions, which is understandably obvious. And with next slide, please. Now, with regards to whether the provider was understanding and responding to emotions. Now, this is important. So in a clinic visit, if a patient is tearful, you would be able to offer them, you'd be able to show your sympathy to them. You'd be able to express your sympathy for them. Whereas in a telemedicine visit, some of these become really challenging. So, but again, our response rate was about 75% of our patients were satisfied about this fact. And then with regards to post-visit formalities, like getting a discharge summary or communicating an action list, what to do before the next visit. So those kind of things are technically thought to be more easier in an in-person visit, but our patients did report that with telemedicine also their level of satisfaction was pretty high with this. And the same thing is with pre-check-in procedures. So typically with an in-person visit, you need to, patients are typically filling out 2 or 3 forms, and their vitals are measured, and they're asked a whole bunch of questions, and then their room. Whereas some of that is expedited in a telemedicine visit. And so the satisfaction levels for that was also pretty high. Next slide, please. So when we asked this question as to whether they got enough face-to-face time with their provider in the telemedicine visit compared to an in-person visit, we were a little surprised. We thought that it would be an overwhelming response, but we only got about 35 to 40% patients that felt like they got adequate face-to-face time with the provider. And we still don't know why that is the case. Next slide, please. And when we asked as to whether in the future they would prefer an in-person visit or a telemedicine visit, remember these are established patients with multiple sclerosis, we got about 2/3 of our patients said yes, they would want to do a telemedicine visit, and 1/3 said they would do an in-person visit. Next slide. With regards to what aspects of telemedicine were beneficial, the 3 main aspects were less travel time, less work time off, and decreased exposure to COVID. So clearly out of the top 3 indications, only 1 was related to the pandemic, and the other 2 were not related to the pandemic. And then there were other factors as well like cost effectiveness, gas expenses, time off from family. So if it's a mother that has multiple sclerosis, she has to, she has to make sure, she has to arrange for the care of her children before when she comes for a doctor appointment. And there were other causes as well. Well, these were open-ended questions, and so I decided to put these, responses based on the frequency that we got. Next slide, please. So, what aspects of telemedicine were thought to be unfavorable by by our patients? So, one is limited physical exam. This was the leading deterrent from telemedicine, which is again quite understandable. And then patients with lesser disability were agreeable with more virtual follow-up visits and less frequent in-person visits. So if they had less disability, then they were more agreeable with telemedicine visits. But I guess when their disability levels were high, I guess they might have had a perception that that they were not being assessed well for their impairment on a telemedicine visit. Of note, I guess for the audience, we did not do an EDSS quantification in our patients. However, it should be noted that even on telemedicine visits, it is possible to do a tele-EDSS score, which is validated in this particular study here that I've quoted. So there were concerns amongst individual patients for recognizing subtle changes in ambulation, weakness, and spasticity. Next slide, please. So in conclusion, telemedicine-based encounters have high rates of acceptability and satisfaction among patients in the practice of MS. Patients were able to identify specific areas of benefit from telemedicine visits, both related to and unrelated to the pandemic. And telemedicine encounters were perceived to be time efficient by patients. Next slide. Physical examination related concerns do exist in telemedicine-based encounters. However, particularly in a field like MS, in particular in a field like neurology, and more specifically in the practice of multiple sclerosis, but how much of this is going to impact medical decision remains a question, particularly in follow-up visits. So if it were a new patient whom I'm trying to assess for multiple sclerosis, it would be quite challenging both for the provider and for the patient, in my opinion, to engage in a telemedicine visit. Whereas with the established patient visit, it may be more acceptable by patients and providers. Quality improvement based on the surveys can help improve access to care that can be disrupted due to socioeconomic factors. Although this study was done at the time of a pandemic, clearly there are other non-pandemic related factors that is worth looking at in detail. And so future areas of study would include assessing physician or provider-based metrics. I did plan for that as part of the study, but we could not accomplish that. But yes, that's definitely something to consider as well. And compare telemedicine and in-person visits for new patients. So initial patient encounters versus established patient encounters, and also for patients with multiple sclerosis versus other specialties within neurology. So these are some areas to do further studies. Yes, I agree that we have not done any statistical analyses in our study, and this was mostly meant to be a survey study. So next slide, please. Thank you so much. So that's my presentation.
Great, thank you so much. That was really interesting. I'll let the audience ask me questions if they have any. Emmanuel, go ahead.
Yeah, so it's really nice work, and I agree with you that it would be interesting to be able to compare to satisfaction with in-person visits. So all the patients you approach, how many physicians contributed actually to those visits?
3.
Okay.
It was not a great, in that sense, it was not a great variability. So 3 patients.
Which is not, I mean, which is good to some extent for, showing some consistency. And do Do you know if, so the other question I had was, do you know if among the patients, you know who has relapsing remitting and who has progressive MS, and to understand whether, because my guess would be that patients with progressive MS are probably less satisfied because they know the examination may be more important in their case to monitor progression of the disease. So do you have that kind of information?
We do not, Dr. Waban, we do not have that that metric. There is one other factor. So I did look at a study that was done again before the pandemic, where they actually did a randomization of in-person and telemedicine visits. So when somebody came to the clinic, they told them, well, your next visit, you'll be randomized to either a telemedicine-based visit or to an in-person visit. They did not look at any satisfaction metrics, as far as I know. But I guess, and obviously it was done before the pandemic, and it was done in, I guess, a semi-urban setting. So it was not in a big city. Yeah, so I guess doing a randomized study will also, with a larger, and the sample size was just 33 for that study, but it was 30 or 40 or something like that. So I guess doing a large scale study will also bring out more details for telemedicine based encounters.
Ethel, do you want to go ahead?
Yes, thank you. Thank you so much, Ram, for your presentation. Congratulations. It's very interesting to see in numbers what we are doing in the clinical practice today. I myself, I'm performing about 2/3 or about 50-50 in the clinic and in telemedicine. And I was wondering if you have the data about the patients that were visited in telemedicine, that the physician needed a clinical consultation, that telemedicine was not enough. Do you have that percentage?
I don't have that data. Actually, I can tell you, yeah, I don't have that data. And the reason for that is we did not survey the providers. So that's one of the things that I wanted to do as a next phase in the study, is to survey providers and find out how many times did they think that a telemedicine visit is not adequate. And I personally, in my own practice, I've thought that so many times that this is not adequate. But I wonder if that question should also be asked to patients, if they thought in the future. Yeah, so that's something I never thought about.
Thank you.
Great, thank you so much for the really interesting presentation to yourself and to our other two speakers today, and we'll close the meeting now. And so we'll meet again at the end of April. And so if anyone has any suggestions for speakers, please let either Ethel or I know, and we can reach out to them. And again, thanks so much, Ram, and the other speakers for the really interesting presentations today, and hear from you again soon.
Thanks for the opportunity.
Yeah, thanks again. Bye, everyone.